Thanks for taking the time to watch our video on team leads and ALS calls. It may seem silly to you that we need to take the time to define what constitutes an advanced life support call, or what it means to be a team leader, but we want to make sure that each of our students has a consistent clinical experience and that everyone is on the same page. We'll try and keep it as short and concise as we can. The topics that I'm going to cover in this video include the definition of an ALS call, the definition and explanation of a team lead, and a discussion of what constitutes a prompt relative to a team lead. First, let me define for documentation purposes what constitutes an ALS call. Lest you think us crazy for including some of these items as advanced life support, I would like to preface this with the idea that we've simply taken the list from the commercial product we're using to track skills and clinicals, also known as FSDAP. FSDAP is a nationally utilized website that generally follows the Committee on Accreditation of EMS Program guidelines and makes it easy for us to track our students' progress. It helps us meet our required objectives for program accreditation, and it cuts back on papers that could get lost or damaged. With that said, the items that are recognized in FSDAP to be ALS calls, and therefore what our program has adopted as an ALS call, include the following: any IV attempt, a primary impression of cardiac arrest, any medication administration other than oxygen, EKG reading or acquisition, any airway device placement other than an OPA or an NPA, and that could include an iGel, a King airway, nasotracheal or endotracheal intubation, digital intubation, LMA, or any other device that may come out. An ALS call also includes any of the following skills: 12 lead, cricothyrotomy, nasogastric or orogastric tube placement, field amputation, Foley catheter, suture, pericardiocentesis, chest tube, blood glucose level checks, central line placement or management, capnography or capnometry, Valsalva's maneuver, carotid sinus massage, blood draw, autopsy, IV removal, ophthalmoscope, otoscope, ET tube suctioning, CPAP, and chest decompression. Let me just review the ones that may have been a bit surprising to you. Yes, a blood glucose check is in fact considered an ALS skill. Any patient who is placed on capnography is considered an ALS patient, and any patient placed on CPAP is also considered an ALS patient. Locally, those skills seems to have migrated to the BLS level. Keep in mind, though, that we're not training these people to be Texas paramedics, although we are a pretty amazing bunch, but we're training them to be paramedics wherever they may choose to work in the U.S. Now I'd like to move on to defining the team lead concept for EMS education. A student who has completed all of their clinical training, i.e. our college's fourth semester students, is eligible to take the team lead role for a call. Fortunately, you are already familiar with the team lead concept. The team lead, when you don't have a student riding with you, is the person who takes the call. The one who rides in the back of the truck with the patient to the hospital, makes decisions regarding treatment, and the one who generally completes the documentation for that patient. A student, then, who takes the team lead on the call should be able to do most of the same things that you would do for the patient. Take a history, request assistance from first responders or a partner, and select the appropriate treatments for the patient. Basically, the student should be able to stand in for you on the call, and you should be able to step back and watch. Students aren't perfect, though. They're still learning. Sometimes they will forget something or pick a wrong medication, and you, as their preceptor, will have to step in and guide them briefly, and then step back and continue to watch. If you have to step in and guide a student, this may or may not impact their ability to, for documentation purposes, call their team lead successful. Here's where things get a little bit tricky, and this is really the whole reason we've put this video together for you. Sometimes when you step in and say something, it's considered more of a critique. For example, wouldn't a 20 gauge IV catheter be okay in this patient instead of that 18 gauge? Sometimes when you step in and say something, it's really much more of a prompt. Don't you think your cyanotic patient would benefit from some high-flow oxygen? Differentiating a critique from a true prompt is important for our students' paperwork. Let's take a look at their form. You can see on the form the student must fill in information regarding the date and call type, patient age, and please list an approximate age if you don't know. The student should select if the call was a BLS or ALS call, and should document the category of the patient, either trauma, cardiac, or medical. The preceptor should then fill in the number of prompts that are required and sign the form for each of the successful calls. During the learning process, which we have defined as a minimum of 30 calls, the student may receive prompts from you. However, the student should be able to lead most of the call without prompts. We ask that you document the number of prompts required for each call. If the number is excessive or the student was unable to successfully lead the call, meaning you as a preceptor had to take over large sections of the call, this does not count as a success, and it should not be documented on the form. Only successful team leads should be documented. We don't really want to define a specific number of prompts or specific successful criteria, so to speak, because that takes away from you as a preceptor. Generally speaking, if you and the student agree that the team lead was, for the most part, successful with just a few prompts here and there, then you may count the team lead as a success. If you feel that your intervention as a preceptor was required too frequently or on too significant an error, you may choose not to count that team lead as successful for the student. And now, for the most important part. What exactly defines a prompt? Again, you may find it silly that we have to define it, but we want to make sure that our students have a consistent experience between preceptors and that the students know what to expect. A prompt is defined as when a preceptor must remind a student to perform a task or ask a question in order for the care provided to the patient to meet the standard of care as would be provided by an entry-level paramedic. This could include interventions that are time-sensitive, such as an immediate 12-lead EKG in a cardiac chest pain patient, or the need to provide BVM ventilations to a respiratory patient. These are items that must be done to appropriately care for the patient. Other examples could include repeat vital signs prior to repeat dosing of nitroglycerin, or asking about allergies prior to medication administration. Additionally, a student may forget items that should be done, but may not lead to actual harm of the patient if they are omitted, such as assessing a blood glucose level on an intoxicated patient, providing pain medication, or anything else that is generally expected to occur on a call to improve the patient's outcome. Local standards do apply here. For example, our systems all locally carry narcotic pain medication and are expected to use it appropriately. Just because some systems in other states do not carry narcotic pain medication doesn't mean that it's okay for our medics to omit pain medication. These would also be considered prompts. Lastly, any items that could be done for the patient or are location or protocol dependent, such as requiring a 12-lead prior to administering nitroglycerin, or perhaps the use of one drug over another for sedation. For example, midazolam versus ketamine versus droperidol for sedation of a combative patient. Those aren't really necessarily prompts. The student may not be familiar with system specifics. These would be considered critiques or recommendations rather than requirements, and therefore are not prompts for the purposes of our documentation. Disorganization, unless the level of disorganization reaches the point where the student can't manage the call, timeliness of non-critical interventions, communication issues such as tactfulness, these are not considered prompts, but critiques. Now I'd like to return to the form. On the back of the form, or the second page, you will note a place for the statement of competency where you will be asked to sign verifying that a student is competent in his or her ability to take the team lead and manage a call. This signature may not be completed until the student has documented 30 successful team leads. The signature of competency indicates that you feel comfortable with the student's ability to manage the calls. The expectation is that upon completion of the student's field internship, he or she should be able to effectively manage a call with a single patient from start to finish. The final signature from you indicates that they were able to do so without any prompts whatsoever from you. Critiques, of course, are still okay. Although we ask you to sign off on a single call, we do expect students to demonstrate progress through their calls. If a student has reached roughly 20 team leads and is still requiring multiple prompts, please discuss this with the student and help the student make a plan for improvement. Additionally, please contact Temple College program faculty regarding the potential need for remediation or additional shifts to meet this competency requirement. Thanks again for taking the time to watch our video, and also for all that you do as our field preceptors. We couldn't help create the next generation of amazing paramedics without your help. As always, if you have any questions regarding this video, don't hesitate to contact me.